Professor Geoffrey Lindeman is speaking about breast cancer prevention and the BRCA-P clinical trial, which is a very, very exciting research that we started about 6 months ago here in Australia. Geoff is the joint head of the Cancer Biology and Stem Cells Division at the Walter and Eliza Hall Institute and a medical oncologist at the Peter MacCallum Cancer Centre and the Royal Melbourne Hospital. So Geoff is joining us from Melbourne tonight. So hi, Geoff.
Thanks very much, Anna. Hi, and thanks for the opportunity to participate and for the two previous speakers for great talk. So look, I might begin. In a sense, what I'm going to talk about very much extends on what Nick has just been talking about, and that's prospects for cancer prevention. But I guess this is focused on the high end of the spectrum of that genetic subset that Nick was talking about. So really, Nick's covered this nicely, but cancer is inevitably a set of genetic mishaps that can happen to breast cells, and really ultimately breast cancer is a manifestation of those mutations and things gone awry. But when we think about breast cancer, as Nick has pointed out, a lot of it is either sort of bad luck or perhaps due to modifiable factors that you've heard about. But genes can play a very important role. And for example, I've got listed on the left side there below the yellow box some of the genes that we think about that people can be born with, which if they carry a fault or a mistake can predispose to breast cancer. So probably about 5% of breast cancers are considered to be hereditary in this sense. It's probably another 15-20% are due to a set of what we call low risk or modifier genes, which together can collectively increase the risk of developing breast cancer. So I'm going to focus on BRCA1 primarily today. That's really at the top of the pecking order for breast cancer risk. And for both BRCA1 and 2, if you think about it conceptually, probably about 1 in 400 people carries a fault in this gene. If you do the back of the envelope calculations, that's about 60,000 Australians who could carry a faulty copy of one of these genes. And of the almost 20,000 breast cancers that are predicted to occur in Australia per year over the next few years, about 400 of those could be due to a faulty BRCA1 or 2 gene. So turning to BRCA1 specifically, this really, if a person carries a faulty copy of the gene inherited either from their mother or father, then up to the age of about 85, they have something like a 72% chance of developing breast cancer. And often these can be early onset cancers in the 30s or 40s. Even developing one breast cancer may set a person up for carrying a risk of developing another breast cancer, up to 40% risk over a 20-year period. Faults in the BRCA1 gene can also predispose women to developing an aggressive form of ovarian cancer known as high-grade serous ovarian cancer. The cancers of the breast that one sees with BRCA1 mutations are often triple negative in nature, and Prue very nicely introduced those as being cancer cells that lack hormone receptors and the marker HER2. As I've mentioned, the tumours can be clinically aggressive. They tend to be ER negative and often carry this triple negative phenotype. Because of that, patients often require chemotherapy, and endocrine therapy is less often used, or hormone therapy. Now, what can one do in terms of mitigating against breast cancer for these BRCA1 carriers? Well, probably one of the most important things is really just very active surveillance. So if a woman is known to carry a mutation in BRCA1, then the current recommendations would be that she engages with a specialist for regular follow-up, and that's usually an annual review, and radiology scans, which would include a mammogram and MRI scan, usually from about the age of 30. So we know that this works. We know that early detection can improve outcomes. But of course, this is a screening tool, and it doesn't mean that breast cancer will be prevented. It means they can be picked up earlier and therefore be much more manageable and much more curable. For BRCA1, it's known that sometimes interval cancers can occur, and these are cancers that occur between the screening period, due in part to their rapid growth, development and growth. So that's, I guess, made people think about what preventive strategies can be used for women with a faulty BRCA1 and also BRCA2 gene. And I guess at one end of the spectrum is removal of breast tissue, and that's usually through a prophylactic mastectomy with breast reconstruction. So this is highly effective, at least a 95% reduction in risk of developing breast cancer. But of course it can carry with it some surgical or cosmetic risk. Not everyone has a perfect outcome, and there are sort of real risks that can be associated with the surgery. And in part, I suspect because of this, uptake is far from universal for breast prevention surgery. And in Australia, it's probably sitting at about 25 to 30% uptake for bilateral mastectomy. And of course, this can happen at various age groups. Because of the increased risk of ovarian cancer, often BRCA1 mutation carriers are advised to have their tubes and ovaries removed at the age of 40. For BRCA2 carriers, it's often by age 45. And this is really valuable to help prevent ovarian cancer because there really aren't very good screening tools for that. It used to be thought that having your ovaries out at an early age because of the hormonal effects could prevent breast cancer, but the current belief based on clinical studies is that it's unlikely to be very effective for that. So it's really for the ovarian cancer mitigation. Now, Nick has very nicely mentioned tamoxifen. Now, whilst the benefit is well known for high-risk women who don't carry a mutation, and there's something like a halving of the risk of developing a breast cancer in high-risk women, the benefits are actually much less certain for BRCA1 carriers. And you'll remember that tamoxifen really is an anti-estrogen, and it's been shown to prevent ER-positive breast cancers. It hasn't ever really been shown to prevent ER-negative breast cancers, and most cancers that arise in BRCA1 carriers are ER-negative. So really the benefits there are quite uncertain. The uptake in the clinic for tamoxifen has also been low in this particular subset of women due to real or perceived side effects. So really it remains an area of unmet need. There's surveillance, there's surgery at one end of the spectrum, and we really don't have an effective preventive strategy for BRCA1 carriers. So our laboratory has spent a number of years trying to understand the cellular and genetic basis for breast cancer, and really that's with the hope that we can try to either treat or prevent breast cancer in the long term. And I'd just like to briefly mention some of the work that we've been doing to try to identify the different cell types in the breast, in particular stem cells, which are the mother of all of the ductal tissue that occurs in the breast, and ultimately gives rise to the tissue in the breast, which is we know is the source of breast cancer in women. And over the last 10 to 15 years or so, we've been able to characterize stem cells, the ancestral cells of all cells in the breast, and the daughter cells and the more mature cells through work both with human tissue and other preclinical models. And some years ago now, we were able to discover that it's the daughter cells of the stem cells, which are called luminal progenitor cells, which you can see in the middle of the screen there, which are the cell types which are most likely to give rise to triple-negative breast cancers. And in particular, we were able to show that these cells are almost certainly the cells of origin, that when they become faulty, give rise to tumours in BRCA1 mutation carriers. So it's these luminal progenitor cells which go awry, and therefore trying to switch these cells off before they become faulty became an area of great interest. And one of the things that Emma Nolan, when she was a PhD student in our lab, discovered was that these cells carried a marker called rank. And we found that the rank signaling pathway was very important for making these cells cancerous. So to cut a long story short, we were able to show, using a variety of laboratory models and also in a pilot study in women with a BRCA1 mutation, that rank signaling was really important in BRCA1 breast tissue. These cells carry rank. That helps promote the growth of these cells, and they can undergo cancerous changes because they're highly proliferative and also have suboptimal repair following DNA damage. And these cells then can give rise to these triple negative breast cancers. We were able to show that you can switch off the rank pathway in these cells before they become cancerous, and that raises the prospects and hope that switching off rank could actually stop breast cancer happening, or at least delay breast cancers from happening in BRCA1 mutation carriers. So by targeting rank, we used a molecule, an inhibitor called denosumab. So denosumab is an antibody that's been developed for use in the clinic for other purposes and switches off rank ligand and shuts down the rank signaling pathway. This pathway has been shown to, when it's switched off, to actually have positive effects on the immune system. And the most important thing about denosumab is that it works very effectively on bone, and it's been used to help keep bones strong. So it's been used to treat osteoporosis. And in the breast cancer setting, it's been in widespread use to help treat bone metastases from breast cancer. Its safety profile is well understood, and particularly at the lower doses used to treat osteoporosis, it has a very good safety profile with minimal side effects. So our hypothesis is, and that's the basis of the BRCA-P study, is that denosumab will reduce the incidence of breast cancer for BRCA1 carriers. And so with the Breast Cancer Trials Group and an international team of investigators, there are actually 7 countries involved, including Australia. We have developed the BRCA-P prevention study. And for this study, almost 3,000 BRCA1 women around the world, about 300 from Australia, will be recruited. These are women who are well and haven't been affected by breast cancer and are not currently planning a mastectomy. They will be randomized to receive denosumab on a 50-50 basis with placebo. So this is because it's really important. If you want to get a drug to the clinic, you really have to understand how it performs against standard of care. And so a placebo control is very important here. And women will receive denosumab through 6 monthly injections for 5 years, in addition to their standard, careful monitoring. And so being on a study will facilitate monitoring and I guess top standard of care, but also provide them with access to denosumab to see whether or not this is safe, tolerable, and can prevent breast cancer. As I've mentioned, the primary objectives are try to reduce the incidence of breast cancer. What we'd really liked is to prevent it altogether, but even if we can delay the decisions to mastectomy, that would be a fabulous outcome. Other aspects that will be studied will include the safety profile, the effects on bone. We expect that denosumab will be very helpful as a bone builder. So, for example, postmenopausal women who have their ovaries removed are prone to osteoporosis. So denosumab may have a positive effect there. We'll be interested to know whether or not it reduces the risk of other cancers. And there's a very important part of the study where we'll be looking at quality of life for patients with Phyllis Buto and other psychology colleagues. So this study's open at some 15 sites around Australia, so it should be readily accessible to women wherever they live in Australia. through the trials group, and you can look up this list here. But probably most importantly, if you use your favourite browser, whether that's Google or not, and look at the Breast Cancer Trials website and look up BRCA-P, you'll be able to readily find more information on that and how to access this study. And there's also a video there which goes into more detail than I've had time to do today. So I'll leave it there and take some questions, Anna. Thanks.
All right, thank you, Geoff. That was fantastic. Just on BRCA1 and BRCA2 mutations, if you have those mutations, what's your risk of developing breast cancer in your lifetime?
So for a BRCA1 carrier, it's thought to be about 72% based on the latest studies. That's up to age 85. BRCA2 is probably about 69%. So it's not insubstantial. And you have to think about that in the context of the average woman that I guess Nick was talking about. That's about 12.5% lifetime risk over that period. So there's significant amplification of risk, and these are often in younger women. So there's great incentive to try to prevent or delay breast cancers happening.
Well, it certainly has tremendous potential, I think, this trial to change practice for so many women who are at high risk. Geoff, if I could ask you one more question. We've received a question from Cheryl, who has asked, what is considered a family history of breast cancer, and therefore when should you be tested for a genetic mutation?
Look, I think that's a really important question, and the answer is complex, but basically and the iPrevent, for example, would be quite helpful here. But if a person has 2 or 3 family members on one side of the family who have either had breast or ovarian cancer, that's an important signal. Ovarian cancer in a family member before the age of 50, breast cancer before the age of 40. They're the sorts of, if you like, alarm bells which would trigger genetic testing for an affected person. Normally genetic testing happens in a person who's been affected by cancer. You find the mutation, and then you can test other family members to see whether they do or do not carry the mutation. Sometimes it's possible to self-fund genetic testing if there are no living family members and you're worried about a family history. There are also certain groups which might be at increased risk. For example, women of Eastern European Jewish ancestry or Ashkenazi ancestry may have a higher risk of carrying a faulty BRCA1 or 2 gene. Male breast cancer, they're the sorts of things that one would look for. But there are good websites, including iPrevent, where people could look for that, or of course talk to their doctor.